Welcome to Podcast UK.
Today we'll be focusing on cleft lip and palate repair.
Hello and welcome to this Podcast UK episode, which is all about cleft lip and palate repairs. I'm delighted to welcome back Miss Nitisha Narayan, a consultant plastic surgeon with a specialist interest in cleft lip and palate repair, who works in the Bristol Cleft Centre. Welcome back to you, Miss Narayan.
Thank you, Matt.
So to begin, what is the key anatomy of the normal lip, and how does this differ in unilateral and bilateral clefts?
It's very important to understand the anatomy of the lip, just the basics of it at least, so that we understand the pathoanatomy of a cleft, so that we then understand what we need to do to reconstruct the lip. So I'll start with a bit of a basic normal anatomy of the lip. The most important structure that we're going to talk about is the orbicularis oris muscle. So it's quite a complex muscle of the lip. It's got four quadrants, the upper, lower, and the left and right ones. It's got some deep internal fibers, which are known as the pars marginalis, which run circumferentially between the two modioli, and they kind of act in like a purse string manner to facilitate feeding and oral continence. And then you've got the superficial, more external fibers. They're called the pars peripherales. They fan out obliquely from the modioli to interdigitate with the other muscles of the facial expressions, like zygomaticus major or depressor labii, etc. And then some of the fibers also insert into the skin as well. So really, the peripheral fibers, the role is that of articulation and facial expression. So the normal lip has the central philtrum, and it's got philtral columns on either side. They in turn arise from each peak of the cupid's bow, and their ridges are created by the insertion of the pars peripheralis's fibers across the midline. The central dimple sort of reflects the absence of muscular insertion in the midline. You've got the white roll of Gillies. That is a muscular cutaneous ridge at the junction between the dry vermilion and the skin. And then you've got the red vermilion, which has an associated midline tubercle caused by an eversion of the opposing pars marginalis fibers in between the dry and the wet mucosa. And then it's important to know the blood supply, because that all changes as well when someone has a cleft. So the blood supply, as we all know, to the lip is from the superior and the inferior labial branches of the facial artery. And it also gets some branches from the maxillary, as well as the transverse facial branch of the superficial temporal artery. And then what's important is the ascending septal branch of the superior labial artery, which supplies the columella. And the backflow within this vessel is quite important, because it preserves the philtral viability in a bilateral cleft lip repair, where we'll come to that a bit later. In terms of the nerve supply, it's from the facial nerve, the buccal and the mandibular branches, and the sensory nerve supply is from the infraorbital for the upper lip and mental nerve for the lower lip. So that's very basic anatomy of the lip, and we don't really need to know anything more. So what happens in a unilateral cleft lip? The clefting leads to is a misdirection of the orbicularis oris muscle and leads to an abnormal attachment. So on the cleft side, it's directed vertically with the insertion of the fibers into the cleft side nostril and also in the periosteum of the piriform aperture, and also onto the lateral aspect of the alar and the nasolabial fold. On the non-cleft side, it inserts into the base of the columella and the nasal septum. So it's important to know where these fibers are inserting to understand what forces then come into play that lead to the abnormal anatomy of the nose. So what this leads to is a splaying of the alar cartilages with broadening of the nasal tip and a shortened columella. So when we talk about the lip elements, the non-cleft side is known as the medial lip element, and cleft side will be known as the lateral lip element. So what happens is the cupid's bow on the non-cleft side is preserved, but on the cleft side, the bow is sort of sloping with shortening of the lip at the point of the cleft side peak. The proposed peak of the cupid's bow is less demarcators, and that's what we kind of have to figure out with our markings. And then there's something called the Nudolph's point, which I just wanted to mention, where the white roll and the vermilion mucosal junction begin to converge medially. So there's a couple of ways of knowing where it is actually an arbitrary point, because it's not really a bony point. So anything on soft tissue is really an arbitrary point. So when the vermilion mucosal junction and the white roll are petering out, that's where you have the Nudolph's point, and you also can measure the height of the vermilion in comparison to the normal side. And so wherever you find it similar to the normal side, that is your Nudolph's point. So you want maximum height at Nudolph's point, basically. And then in terms of more bony changes, so you obviously have an instability of the dental arch segments. So that results in a collapse of the lesser alveolar segment and a lateral rotation of the greater segment, with the greatest deformity occurring with the most severe clefting. And then in terms of the vascularity, the superior labial artery will not be able to pass horizontally through the lip, and therefore it anastomoses with the lateral nasal artery on the same side. So that's what happens in a unilateral cleft lip. I'll just briefly mention what happens in a bilateral cleft. Slightly different. A few things are slightly better because it's a bilateral, so there's more symmetry. But bilateral clefting of the lip, let's say if it's the lip, alveolus, and the anterior palate, it would result in a classic central segment, which is sort of the remnant of the medial nasal process of the frontonasal prominence, which we talked about in embryology. So it's got a soft tissue element and it's got a bony element. The soft tissue bit is called the prolabium, and the bony element is called premaxilla. And these are entirely separated from the lateral lip and the maxillary arch. And the combined effects of this sort of unrestrained cartilaginous growth and anterior pressure of the tongue often result in the premaxilla being very prominent. It's also known as proclined. So that's the reason why you see that blob of tissue, which has both bony and soft tissue element, being quite prominent before the cleft is repaired. The nose is quite broad and quite flat. The domes are quite widely separated, and the columella is very short. It can even be absent in very wide bilateral clefts. The prolabium tends to be deficient in the vermilion and the white roll. In complete bilateral clefts, it lacks, and it wouldn't have any orbicularis muscle if it's a complete cleft. If it is an incomplete cleft, it may have some orbicularis fibers going across. In terms of the blood supply, if it's a complete cleft, the prolabium is not going to receive any arterial supply from either superior labial arteries, and it's completely reliant on the terminal branches of the septal, posterior septal artery, which comes from the sphenopalatine artery, and also the anterior ethmoid and the lateral nasal arteries. So basically, it's more dependent on the maxillary supply as opposed to the facial artery. So that's kind of summary of the normal anatomy of the lip and what changes you can expect to see in a unilateral or a bilateral complete cleft. And of course, in an incomplete one, you're going to see just a variation in severity of all of these elements to variable degrees.
Fantastic. What are the key goals in cleft lip repair, and what is the typical timing?
Okay, so I think we did discuss the timing of surgery before, but essentially just as a repetition, we tend to do the lip repair between 3 to 6 months of age. And in terms of the principles of repair, the idea is to approximate the medial and the lateral lip elements at all the levels. So at the level of the nose, the cutaneous roll, the vermilion cutaneous junction, and the vermilion mucosal junction. And you repair the cleft in layers. So you repair the skin, the muscle, and the mucosa, whilst maintaining the natural landmarks of the lip, which we just talked about. The second goal would be to maintain lip length symmetry as best as possible. And then in terms of the scar, you want to place the scar along the natural lines whilst appreciating the anatomical subunits of the nasolabial complex. The nostril margins should be of equal circumference as best as possible. If you want to err on the side of caution, I would probably make the nostril circumference maybe a millimeter or a couple of millimeters bigger, because you've got to account a little bit for scarring. What you don't want is to create small nostrils. This is very important because it's really, really difficult to treat a nostril that's too small. So I'd rather have a slightly bigger nostril on the repaired side than have something smaller. And then last but not the least at all, you want to completely release the abnormal attachments of the orbicularis muscle before undertaking a fully functional muscular reconstruction. So that's sort of the principle behind cleft lip repair. And it doesn't matter what technique you use, but you just go by these principles.
Fantastic. Thank you for explaining that. What are the main techniques used in cleft lip repair, and how do you choose the right one for the patient?
Okay, so I think in terms of the techniques, there's been multiple techniques that have been described. So they range from a simple elliptical closure, which is called Rose-Thompson technique, where, just how you excise lesions using an ellipse, which slightly lengthens the scar by, well, it's shown that it lengthens the scar by 1 millimeter when you do that, to multiple similar techniques. And all these techniques have evolved over the years. But if I were to talk about two main techniques that are currently being used in the UK, I would say, first of all, a rotation advancement type of technique, which was originally described by Millard. So either a Millard style rotation advancement or a modification of that. And the technique that is most popular currently in the UK, as per the Cleft Collective data, is the Fisher style anatomical subunit approximation technique. So I tend to use the anatomical subunit approximation technique. And so as cleft surgeons, I think it pretty much depends on what your training has been. So I'll describe a little bit those techniques. It's a little bit difficult to do that on a podcast, but in a rotation advancement technique, it's a cut and go technique. So you sort of create a back cut which goes into the philtrum, and you create flaps in such a way that you're able to close the cleft. And the scar there's a horizontal scar that goes along the nasal skill, and then there's a vertical scar that goes along the upper lip and into the mucosa as well. With a subunit technique, essentially the idea is to create the scar in the natural subunits of the nasolabial complex. In terms of teaching and training, I feel like you need more experience to be good at rotation advancement. It's got a longer learning curve. The Fisher technique looks very complicated because it's got lots of points that you have to mark, but it is a really good technique in the sense that it's easier to learn and it's reproducible, and it does ensure that you are not going to create a short lip. And of course, the rotation advancement technique from Millard has been modified multiple times. So there's been a lot of changes made to that technique, and individual surgeons have their own versions of that. We don't tend to sort of change the type of technique used based on the cleft, but I think each surgeon, the way they've learned. So for example, if I've learned the subunit style technique, I tend to use that for all of my cleft patients. That's the one that I learned, and that's the one that I also described in the exam. But some people do find it easier to describe the rotation advancement repair, and that's absolutely fine in an exam situation. And also in, real life practical situations, it doesn't matter what technique you're using, as long as, the outcomes are good in your hands. I would like to describe the Fisher subunit style technique in a bit more detail. And really, in terms of talking about it in the exam, there's not a lot of time. So you talk in principles about what you want to achieve in terms of the goal. And then you need to just be able to draw the incisions of what incisions you're going to use for the repair. So what lines, points you're going to draw on the medial lip element, and then draw the points on the lateral lip element. And then they want to see what the final scar is going to look like. And that's all they want. And you need to be able to describe that within a minute. In terms of talking about it, we talked about it before, that there's a really nice YouTube video from Mark Swan. I think it's uploaded by one of our trainees, whose name is Pavika. It's very easy to find on YouTube if you look for Fisher subunit style technique. So in terms of the practicalities, that is a good video to look at. But in terms of the principles, what you're actually going to say in the exam is talk about the fact that in a real situation, I'm going to use calipers to measure the points accurately. But in this situation, I'm going to show you quickly where the main points are going to be. So you start by marking the columellar lip junction points. So you mark the midpoint first and then 2 points around it. And then you mark the points on the lip, which include the troughs, the cupid bow, and the corresponding points at the white roll, as well as the wet and dry mucosal junctions. And then once you've done that, you mark the nude-off point on the lesser segment, which is the cleft side, and then you do your measurements. So in terms of the measurements, you want to know on the normal side, what is the total lip height? That is from the lateral columellar lip junction to the point corresponding to the cupid's bow on the supraroll. That's your total lip height. And you want to then see what is the greater lip height. So what is the lip height on the cleft side? The discrepancy is what you want to know. So let's say your total lip height was 10 millimeters and your greater lip height on the cleft side was 8 millimeters. Now you've got 2 millimeters to somehow find so that you get the same height. So 1 millimeter, remember we talked about the Rose-Thompson effect. So if you cut anything in an ellipse, you automatically get 1 millimeter. So you can remove that 1 millimeter because that's free. You're going to get that anyway. Now 1 millimeter is still left. So what you do is you create a back cut along the upper lip, starting from the cleft side cupid's bow, going towards half of the philtral column. And then into that back cut will come a triangle, which is taken from the cleft side, and that will be equivalent to whatever millimeters discrepancy now you're left with, which is in our case 1 millimeter. So important things to measure would be total lip height, the greater lip height, see what the difference is between the two, -1 for the Rose-Thompson effect, then you're left, whatever you're left with, in this situation, we're left with 1 millimeter. You place an inferior triangle of 1 millimeter into your marking. And that is how you create a lip height which would be symmetrical with the normal side. So if you watch that video, learn how to do your markings, and then learn how to create what the final scar looks like. Talk about the total lip height, talk about the greater lip height, and then talk about the inferior triangle. Those are the 3 things you need to talk about. There's no need to go into any other detail. And then, of course, you're going to start, you would have already told them about the goals of the lip repair. So your principles would already be there. And the markings and the final scar is just going to sort of, augment your answer. So that would be the subunit repair as described by Fisher. Does that make sense?
It does make sense. Thank you for explaining
Okay.
it. As you say, it is very hard. I think it's an almost impossible task to explain.
Yeah.
Yeah, just without the video. But that video is excellent. I've seen it myself, and I believe the name of it is Demystifying the Fisher.
That's correct.
Technique. Yeah, and it's available on YouTube. It's from the Spires Cleft Centre, as you say, and it is really excellent. So well worth a look for anyone who wants to better understand that. But thank you for explaining that as well. And how does that change when we're considering a bilateral repair of the lip?
Okay, so bilateral cleft lip slightly more complicated, and do not worry, they don't really ask you about the bilateral lip in an exam. But just to sort of give you a broad idea about the approaches, there are two main approaches in terms of the surgical repair for bilateral cleft lip. The first one is a Manchester style repair, and the second one is a Mulliken style repair. And also, there have been various modifications of both of those techniques, and there's various authors and surgeons who've come up with a certain modification of either of those techniques. So I won't go into all of their details, but I'm just going to broadly talk about Manchester and then Mulliken. So basically, the difference is the way the prolabial vermilion is used to create the Cupid's bow and the medial tubercle. So in a Manchester style, the prolabial vermilion is used to create the Cupid's bow and the medial tubercle. In the Mulliken style repair, however, the Cupid's bow and the tubercle are reconstructed using the lateral lip elements. So we actually discard completely the prolabial vermilion. And the reason is, so most surgeons in the UK would prefer a Mulliken style repair these days. And the reason is, like I said before, during describing the anatomy of bilateral, there's no orbicularis fibers running through the prolabium, you see. So if you put the prolabium between the two lip elements, there's going to be an area with no orbicularis. And so that, when it all heals up and the child is growing, looks very weird. It becomes quite flat and it looks quite broad with no muscle in between. So it's not a very functional reconstruction. The Mulliken style repair, however, is where the lateral lip elements are used and the orbicularis is repaired in the middle.
What are the most important complications after cleft lip repair, and how do you manage these?
Okay, so fairly fewer complications in comparison to the palate, but let's just divide the complications into early and late. So in terms of early, you can get complications like lots of crusting, blood and mucus forming together a crust, and that often forms like a thick layer on the scar, and lots of parents complain about that. But that's nothing to worry about. It's almost an expected outcome, and that settles as the scar as the wound heals. And there could be bleeding, there could be wound breakdown, wound dehiscences, especially if the child is older. We did have a few incidents after the pandemic when the lips were repaired in older children, and we found that because they were now toddlers and they were more mobile, they kept knocking their lips against, chairs or sofas and that sort of stuff. We had a significant amount of children who were coming back to ED with bleeding and wound-related problems. So really early complications are those. In terms of late complications, they're slightly more unpredictable because even though you're using the same technique on all the clefts, every child is slightly different in terms of how they heal and how the scars are produced. So you can get scar-related complications. You can get stretched or lumpy scars, hypertrophic or keloids. But the earlier you repair the cleft, the lesser are scar-related problems. And we also advise our parents to massage after the wound has healed completely and protect from the sun. Other than that, there may be shortening of one side of the lip or the cleft side of the lip that may need revisions. There could be steps at the white roll, and sometimes there could be abnormal, it looks almost like a bubble of skin in the vermilion area, and those just do very well with simple excisions. So those kind of tweaks are sometimes needed when the child is older. With the cleft, the upper lip can be quite thin in comparison to a non-cleft individual, and so we offer them several techniques to augment the lips in futures. That includes fat grafting or dermal fat grafting, or in some situations even a Abbey flap. especially if they've had a bilateral. So those are sort of the main complications.
So is that for like a sort of whistle deformity type thing, you mean then?
Yeah, sometimes when there's a notch, I described in a bilateral those two types of repair.
Yeah.
So in some situations, if this was done quite a while ago, and the Mulligan style technique had not picked up, and there was still some surgeons using the Manchester style technique, and there was no muscle in between. So that does create a little bit of a notch because the muscles are separate. And in that situation, you have to undergo a full lip revision so that you can reconstruct the muscle in the middle to remove that notch so that the orbicularis is in continuity.
Great, thank you for clarifying that. We're going to move on now to cleft palate. What is the key anatomy of the normal palate, and how does this differ in unilateral and bilateral clefts?
Okay. So anatomy of the cleft palate is very important. No one is going to ask you really about the anatomy of the lip so much, but in my exam, I was asked about all the muscles in a cleft, in a palate, just normal muscles of the palate. But I'll talk about the normal anatomy, and then I'll talk about the abnormal anatomy. So the hard palate is basically the palatine process of the maxilla anteriorly and the palatine bones posteriorly. The soft palate is more of a dynamic muscular sling, and it's got really 5 paired muscles. So you've got your tensor villi palatini. So that's the job of that muscle, is to vent the eustachian tube during swallowing. Then you've got the levator villi palatini. That's your muscular sling that elevates the soft palate. Then you've got your palatoglossus, which is, you say, a depressor of the soft palate, but also it's an elevator of the tongue. Then you've got palatopharyngeus, which is a depressor again of the soft palate, but it also constricts the pharynx during swallowing and speech. And then you've got the musculus uvulae. It's a bit uncertain that it actually has any function, but it's just there. So, and then other than that, you've also got the superior constrictor muscle, which originates from the medial pterygoid plate, but it also assists in the velopharyngeal function. So I think it's important to mention this muscle, even though it's not technically part of the soft palate. In terms of the blood supply, the hard palate is supplied by the greater palatine artery, and the soft palate is supplied by the lesser palatine artery. And the nerve supply, you've got the sensory nerve supply coming from the maxillary division of the trigeminal, and the motor supply is important. So the tensor is supplied by the medial pterygoid nerve, which is a branch of the mandibular, and all the other muscles are supplied by the pharyngeal plexus, which are formed by the vagus and the glossopharyngeal. So that's the motor supplies is quite important to remember. The tensor is mandibular and pharyngeal plexus for the other ones. Now, what happens in a cleft? So if it's a complete unilateral cleft lip and palate, the vomer is still attached to the palate on the non-cleft side. The cranial element of the vomer is vertical. However, it becomes increasingly horizontal as it approaches the palatal shelf. In a complete bilateral, the vomer is attached to the premaxilla anteriorly, but it's got no attachments posteriorly to the palatal shelves. Levators arise from so levator is a very important muscle, and this is the muscle that we concentrate on because it's an elevator of the soft palate. We like to see that muscle when we're dissecting and reconstructing, so that we definitely want to include that in our repair. So it arises from the skull base, and on entering the soft palate, it inserts into the cleft margin of the anterior half of the soft palate. In a non-cleft soft palate, the levator would be attached to the middle 40% of the soft palate. So here it actually goes more in a vertical position. Instead of going horizontal in a normal soft palate, this goes more vertical and goes into the cleft, edge of the cleft, and into the hard palate as well. So that levator is important. And then the tensor, which originates from the skull base, normally what happens is the tendon passes around the hamulus and enters the soft palate and forms a palatal aponeurosis within the anterior third of the soft palate. But in a cleft palate, it attaches to the posterior hard palate shelf. So essentially, the pattern is that instead of going more horizontal and creating a aponeurosis and attaching to the opposite muscle fibers, they're going a bit vertically and they're attaching themselves more anteriorly to the cleft as well as the hard palate, which they're not supposed to in a normal soft palate. So I think these two muscles are quite important. There is a diagram. I learned the diagram from again Mark Swan's chapter in the Oxford Handbook. So it's important. That diagram is quite important.
Brilliant. Thank you very much for clarifying that. Now thinking about goals, what are the key goals in cleft palate repair? And it'd be great if you could just remind everyone of the typical timings as well.
So typical timings, we said before, 6 to 12 months. Sometimes if the cleft is quite wide and if the child has a syndrome or has complex medical conditions which take priority, this timing may be delayed. But if there's no other issues, then 6 to 12 months is normally the time. Goals of repair is to produce a anatomical closure of the defect. You basically want to create a system for development and production of normal speech by repairing, so changing the direction of the muscles and repairing them in the midline and retroposing, so pushing them as back as possible. So remember, the muscles are supposed to be horizontal at the back, right at the back, especially the levator is what we're talking about. So we have to completely detach it from the abnormal attachments, dissect it towards the back, repair in the midline, and retropose as best as possible to create that sling that would then elevate the soft palate so that the velopharynx can be effectively closed for the production of normal speech. And then also to minimize maxillary growth disturbances and dentoalveolar deformities. And we do that by careful handling of the soft tissues.
What are the main techniques used in cleft palate repair, and how do you choose the right one for the patient?
Okay, so in the UK, we're very standard in terms of the cleft palate repair. So like we've talked about the cleft lip repair, there's still sort of a few techniques or modifications of several techniques that individual surgeons are using. But in terms of the palate, we're a little bit more standardized. So it's easier to talk about palate repair, especially in an exam-like situation. So what you're going to say is, you're going to say that we do a intravelar veloplasty as described by Summerlad, with or without lateral release incisions. So you may have heard von Langenbeck technique, whereby the palate is repaired, the cleft is repaired in the middle, in layers, and then there are incisions made on the sides. They're called lateral releases, so that if there's tension, you can relieve that tension by creating those cuts on the side and then repairing the palate in the middle. So that's von Langenbeck's techniques. But von Langenbeck essentially means that you're always doing a lateral release. So you don't always need to do a lateral release if you're doing the intravelar veloplasty in the way Summerlad has described, which basically is a radical technique using a microscope. So very careful dissection of the muscles and almost in slightly wider clefts, possibly islanding the muscular periosteal flaps, perichondral flaps. The dissection is so careful using magnification that you, for quite a few cases, you may not need to do the lateral release, which is why we say intravelar veloplasty, as described by Summerlad, with or without lateral release. So essentially what it involves is, after the child is anesthetized and you've got the mouth gag in, you put in local anesthetic, and then on either side of the cleft, you create marginal incisions. Then you raise the oral mucosal flaps along with the underlying glands, and then you leave the muscle on the nasal layer. Once you've dissected the oral mucosa with the glands off the underlying muscle on the nasal layer, you then, once you've dissected it enough, then you close the nasal layer first, we use dissolvable stitches. So vicryl or monocryl, some surgeons do use monocryl as well. So either is fine. Once you've repaired the nasal layer, the second step is to dissect the abnormal attachment of the muscle and push all the muscle to the back. So that's retroposing the muscles and then repairing the muscle in the midline. So we use 4-0 or 5-0 PDS or Prolene stitch. So use a strong stitch for that, and 2 or 3 stitches are usually enough. Once we've done that, we then close the mucosal layer with the same stitch as you've used for nasal layer, so a vicryl or a monocryl. And that's your intravelar veloplasty or IVBP, Summerlat style. If the cleft is very wide and there's no sort of absolute millimeters that have been described as, very wide, what you need to do is measure the cleft at the hard and soft palate junction and then see what the width of the individual shelves are. If the shelves are really narrow and the cleft is quite wide, you may need to consider to repair them in either stages, or you may need adjuncts like using buccinator flaps, which are muscular mucosal flaps from the cheek to help to get additional tissue to repair the cleft. So everyone sort of manages wide clefts slightly differently. You can either do it in stages, or you can, if you want to repair it all at once, you may need to use adjuncts. But yeah, describing either technique is absolutely fine. So that's sort of, in principle, repair of a cleft of the palate.
Thank you for that. And so that brings us on to our final question now. What are the most important complications after cleft palate repair, and how do you manage these?
So again, in terms of post-op complications, I would like to describe it as early and late. So early complications could be airway difficulties. So this is potentially life-threatening. If you do have an airway issue on the ward, then you immediately call your senior anesthetic and surgical support very early, and then do the initial management as per management of a critically ill child as per ABC. This sometimes you are able to anticipate this. So we talked about Robin sequence previously. We also talked about, again, patients with syndromes. They may already have a high risk factor, which may put them at risk of airway obstruction following surgery. Because remember, at the minute the cleft is open, and once you close everything, you are closing the airway quite a lot. And so some of these children, you may be able to anticipate airway obstruction and therefore preempt either an HDU bed or an ICU bed, and also preempt that they may need additional airway support when they're being extubated. So your anaesthetist will be able to help you with that, but you may need to temporarily place a nasopharyngeal airway if you have been able to predict the airway difficulty after extubation. So that could happen. And then you've got bleeding. So bleeding could be a lot of times if you have done a vomer flap. So remember, you're lifting the mucosa off the vomer bone. So sometimes there's, no matter how much hemostasis you've done, it's quite difficult to actually stop the bleeding from the bone. So you can often get bleeding, significant bleeding after the surgery from the vomer. And I've also seen once bleeding from the one of the perforators of the muscle, which sort of manifested after the adrenaline effect had settled after the child woke up. So that was quite early post-op period. And of course, you can get bleeding from either side of the lateral releases because those are open wounds. We do tend to place a Surgicel in both of them to pack it and control the bleeding, but sometimes it's just you can get oozing or maybe a spurter through those areas. So if that happens, that needs to be managed appropriately. A lot of times it's very difficult to see inside the child's mouth. You need to almost immediately take them to theatre and have your blood ready for blood transfusion if needed. And this is basically an potential airway risk. So you need to take them to theatre immediately. Wound dehiscence can happen quite early, usually first 2 weeks. If that does happen, we tend to say, let's just wait for it to heal. It could be partial, it could be just in one of the layers, or it could be through and through the oral and the nasal mucosa. And so what we do is in the early post-op period is just sit tight and let the wound heal as best as possible. When you see the child in the post-op period, we normally see them in like 3 months from the surgery. When at the time you then reassess what the situation is. A lot of times these wounds just heal, but sometimes they can create a fistula when they haven't healed fully. So coming to the late complications, so palatal fistula would be a late complications. And in terms of fistula management, that would depend on whether this fistula is symptomatic or not. If it's a symptomatic fistula, so if it's large enough for food or drink to pass through, or also enough air escape to cause an impact on speech, then we should repair it. Otherwise, if it's just a small fistula, it's a pinpoint one, and it's not really causing any problems, then you don't really need to take them back to theatre to repair it. The other complication, or I wouldn't say complication, but it is an expected outcome in about 20 to maybe 30% of the children, may need speech surgery. So they present with velopharyngeal incompetence. So the intravelar veloplasty was not enough to optimize their speech, and often then they would need to be investigated to understand how we can optimize their speech with surgery or non-surgical techniques. And then you can get maxillary growth disturbances. So about 20% of young adults or teenagers will need jaw surgery in the future. So those are sort of early and late complications of palate repair.
Fantastic. Well, thank you so much. That's all of my questions. And we'll look forward to you joining us again for our next episode, which is going to be on velopharyngeal insufficiency and speech surgery, which you've just mentioned. So thank you so much to you for everything, and we shall look forward to that. Thank you.
Amazing. See you soon.
Podplast UK is a collaboration between UK and Irish plastic surgery trainees and consultants. The content reflects individuals' practice, and opinions may vary. If you have any feedback, do get in touch. We hope that this has been interesting and useful. If it has, remember to follow us for future sessions.